think Gary, or you can call upon Dr. Ziad, who has been patiently waiting for his talk. Simplify OCT guidance with MLD Max algorithm. All of us are quite familiar with this now, looking forward to his talk. He's the one who is making it very popular. We have other person, Kevin Cross, also is involved in the same. I think we can stop there and start sharing Ziad's. Dr. Ziad, we're sorry for the slight delay because live cases were slightly delayed. Over to you now.
Ziad's apologies, and great to have you.
Hello, everyone. Sorry, I don't mean to put any pressure on anyone. I'm in the middle of my clinic day, so I have patients waiting in the office. So in any case, it's nice to see you. Nice to see parts of a live case. I was able to moderate a live case earlier today. Hello, Gary. Hello, Srini, Ashok, and Sridhar. So I'm going to get right into it and talk about MLD Max and how to simplify OCT guidance. There's a lot of activity going on in the OCT world. You may have heard recently that Abbott has released the next generation of OCT called Ultron. We just did our first cases of it really about 15 or 20 minutes ago. And so more on this in the future about the next steps of OCT. But the good thing is, as Gary has probably described to you earlier, is the importance of developing an algorithm for intravascular imaging is really what gets the best outcomes. Okay, so the best way to handle this, I think, or to talk about MLD Max in the context of a case. So this is a fairly typical case we'd see in the cath lab: moderate right coronary disease, complex bifurcation disease, and a proximal LAD lesion. As is typical in many centers, we calculate the Syntax score in patients with triple vessel disease. This patient has a Syntax score of 22, and the patient elected to undergo PCI, which really means we have to get cabbage-like results specifically on the LAD. So how do we make OCT easy, or in fact, how do we make intravascular imaging easy? We really need to focus on those areas that have evidence to suggest large relative risk reductions in PCI complications and improve PCI outcomes. So we know that in the pre-PCI, we need to understand the morphology, specifically.
Yeah, can you make it full screen, please? We are just press the button below. We are seeing half.
Oh, I'm sorry. I thought I was full screen. Well, how do you see it? Is it still small?
We still see slide view, Ziad.
Sorry about that. I'm actually on primary monitor.
Hit F5. Usually that works.
Yeah, I'm actually seeing. 1 second, guys. Sorry, I'm actually seeing the. I'm going to do a new share here.
Probably you can stop share and do it again.
To jump ahead, in the pre-PCI, we know we need to look at the morphology, which is largely an assessment of calcification. We need to determine accurately the length to make sure that we cover the lesion and also that we land in the most normal segments distally and proximally. And obviously the diameter of the stent indicates how much lumen area we're going to get and is probably the most important predictor of long-term PCI outcomes. Post-PCI, we want to look for medial dissection, and because we know that the presence of an edge dissection, particularly at the distal reference, is an independent predictor of target vessel failure. We're looking for apposition largely to prevent us from getting into complications if we need to re-intervene. That's gross areas of apposition, and we know the clinical utility of expansion on PCI outcomes. And so we termed this MLD Max because it's something that's really germane to interventional cardiologists. We all want to try to get the maximum MLD, and this is an easy way to remember the steps of an imaging-guided PCI and apply them into practice. So for OCT guided PCI specifically, I do want to spend just a couple seconds on how we set things up. You connect the syringe and flush the catheter with whatever medium you're going to be flushing the artery with. So if you're doing a saline guided OCT, this should be saline. If it's contrast, it should be contrast. You purge the catheter with that material. That's simply you're following the steps here on the bottom right-hand corner of the screen. After that, you're going to go ahead and drape the dock. It's very important that you do not hold this black cable. and hang the OCT. There's about $100,000 worth of fiber optics in there. And every time you bend this, you damage some of those fiber optics and your image will get worse. And then you simply connect the catheter and then you follow the instructions on the screen. Once you've connected the catheter, we're going to be looking at positioning the catheter distal to the lesion. We're going to end up purging the catheter lumen. And then we're going to do a little puff to evaluate the clearance to make sure that the guide is engaged. And then we're going to go ahead and perform our pullback. So you can see all of this can be done really very, very rapidly. And in the span of less than 90 seconds, we've done our OCT connection and our OCT acquisition. Now, it's important for those of you who are less familiar to understand the user interface of OCT. And so what you have in the pre-PCI is your co-registered in actually 4D on the angiogram, in the cross-section, on the lumen profile, which I like to call the OCT angiogram, and then in the longitudinal profile. Obviously, one of the benefits of OCT is that it gives you the areas automatically, unlike IVUS where it requires automatic measurements. The OCT is able to detect all of these automatically if you get a good flush clearance. It provides you the L mode and the lumen profile, which is on the bottom, more on that in a moment. And there are important features of OCT which we should acknowledge, and that is the zoom out feature, because in the past when we had the M3 catheter, M5 catheter, it really was very difficult to image the left main. But in fact, now we can zoom out and do the left main, we can do the carotid, we can even do the superficial femoral artery. Now, so let's start with our case. It's 12:30. We're going to do an MLD max guided approach and start by looking for morphology. And so when we look at morphology, of course, it's important to understand the natural and normal layers of the OCT. You can see the innermost layer is the intima, that's bright orange. The inside layer of that is the internal and external elastic lamina, bounding the media. Outside of that is the adventitia. And that's important because anytime we look at an OCT, we're going to be able to look, we want to look for some of those features. OCT is, image interpretation is dependent on the concept of signal attenuation. And to understand that, let's take this hypothetical situation where you flash a flashlight into a bowling ball. If the bowling ball is black, all of the light will become blocked. This is high attenuation. If you shine your flashlight into a crystal ball, of course, the light will hit the crystal ball and refract. So the light is bent, but you're still able to see behind the image. That's low attenuation. So anytime you see any OCT cross-section, we want to ask ourselves, can you see the EL and can you see the adventitia? If you can, the artery is normal or fibrous. And only in this situation, if there's a signal change, do we end up looking for pathology. And by using an algorithmic approach of looking in the rope and the adventitia and looking in the lumen or the wall and understanding high or low attenuation, we're very quickly able to determine what the lesion morphology is for all OCT cross-sections. Now, the most important one from a clinical standpoint is actually the low attenuation signal that you see in the wall, and that's in the lumen, in the wall, and that is calcium. So what you'll notice, if you know calcium is a crystal, so if you shine light through a crystal, the light will refract, and so you're able to see behind it. And the reason calcium is important is because it is the one parameter on morphology that is the most likely to get you into trouble. Because fibrotic and lipidic lesions yield after even direct stenting or compliant ballooning. And even if you end up a little bit relatively underexpanded, high pressure post-dilation can really rescue these areas. However, in the presence of moderate to severe calcification, that's completely different. And once the stent is placed, apart from maybe some preliminary data about IVL rescue, really you're in a difficult situation here. So when you see moderate to severe calcification, you need to think about advanced lesion preparation. We developed this calcium algorithm called the calcium imaging score, in which we created a simple strategy called the rule of fives, where if you have a vessel that's got calcium that's 0.5 millimeter thick, 5 millimeters long, and 50% or more of the vessel arc, you're more likely to be underexpanded, reminding you that advanced lesion preparation, whether it be NC or specialty balloon or atherectomy or IVL leading to calcium fracture is critically important. And this is an example of calcium-dependent lesion preparation where the pre-PCI M for morphology is critically important. You see that there's dense calcification in the artery wall. We perform atherectomy to thin this calcium down. The calcium is fractured by an NC balloon, and then you can get excellent luminal gain. Now, when you do an OCT guided morphology assessment, it really can be done very, very quickly. And all you're seeing is us scrolling through the artery here to look for segments of calcium that are more than 180 millimeters, more than 0.5 millimeter thick, and greater than 5 millimeters long. When we do the length portion, what we're really trying to do is manipulate the angiogram. So if you look at the OCT co-registration angiogram, what the OCT 3D luminogram or automated lumen profile is really a multiplanar reconstruction very similar to TAVR. You've essentially squashed all of the images and the three-dimensional nature of the artery into 2D, and that helps you to determine the optimal reference segments. So when we do that, what we're going to try to do is land our stent into the most normal segment distally, and we want to examine the cross-section and say, yes, this is a nice place for us to land. We want to do the same thing proximally. And when we do this proximally, we notice that there's a segment of disease here. However, this may be the most normal segment of this artery. Now, we don't have a 35.2 millimeter length, and to fit into the concept of precision PCI, we should manipulate the more normal of these two segments, and in this case, that's the distal, by basically pulling it in 2.2 millimeters, and now we end up with a commercially available drug-eluting stent size. And when we do this in real time, you can see that we're looking for a normal segment distally, and we're going to leave a bookmark there. We look for the most normal segment proximally. So we're going to scroll in and out until we see the most normal segment. You'll see we're at 35.2 millimeters, and then we adjust the distal segment inwards to become an exact stent size. Once we bookmark our distal and proximal segments, the next thing that we can do using the MLD Max approach is to determine the diameter. And stated simply, if you're able to see the external elastic lamina, we should use the EL and round down for our stent and balloon size. In situations where we're unable to see the external elastic lamina in about 20% of cases, we want to use the lumen and upsize. We do this for both the distal reference to pick our stent size and distal post-dilation balloon, and also in the proximal reference to pick our proximal optimization balloon. And so this is a very easy task to go ahead and recognize now the external elastic lamina and measure it quickly. We do this at the distal reference, where we can see the EL very clearly. Now, when we go to the proximal reference, you may remember that there's a significant burden of disease, so it depends on the operator's comfort level to be able to identify the external elastic lamina. Here I feel comfortable on being able to identify it. In situations when I cannot, you'll note that we have the mean lumen diameter and can upsize. So if we were to go ahead and analyze these distally, we're a 3.0 by 3.06, so we round down to the close EL that's a 3.0 device. Proximally, I found the EL that's 4.3. We round down to the closest device that's a 4.0. If we use lumen and upsize, we'd end up with a 3.5. So now, again, this has become quite like a TAVR. We know we need a 3.0 by 33 stent. We're going to direct stent based on our morphology, and then we'll use a 3.0 NC distally and a 4.0 NC proximally for optimization. So that took about 13 minutes. You remember we started at 12:30, we imaged, we analyzed, we placed the stent, we optimized in 13 minutes. And now what we're going to do is look at our post-PCI user interface on OCT. And the two most obvious features are that there is an apposition indicator, which is a white bar showing that the entire stent is opposed with less than 200 microns of malapposition, and the rendered stent, which is the stent placed into the artery. One of the main advantages of the rendered stent is that the OCT automatically identifies the edges of the stent, allowing rapid assessment for distal edge dissection. There are some advanced features in the OCT, which include 3D bifurcation mode to assess the placement of stents close to bifurcations. There's also the ability to look at the stent longitudinally in its appropriate branch pattern. And then finally, I think this is a nice feature to be able to show patients, and that's the 3D bifurcation or the 3D fly-through, which lets patients understand how the technology may impact their clinical outcome. For medial dissection, there are 3 types. When we see a dissection into the intima, we really tend to leave these alone. Lorenz Reber and Maria Radu showed that almost 98% of these heal after 9 months. But once we have a medial dissection that penetrates into the media, particularly at the distal edge, there's a risk of progressing into an intramural hematoma, and we strongly suggest stenting these when they're greater than 1 quadrant in arc from the center of the vessel and they penetrate the media. You can see that it's very easy and quick to assess the distal reference and the distal edge dissection because the OCT automatically identifies the proximal and distal edge. Here you do see that there is a distal or proximal edge dissection. However, we know that it's not greater than a quadrant and we can treat it medically. Apposition, of course, is important to understand the difference between the definition of apposition and expansion. Apposition is simply whether the stent is touching the wall. If the stent is touching the wall, it's apposed. If it's not, it's malapposed. In general, treating malapposition treats the physician more than the patient. We should be considering treatment of proximal malapposition that may interfere with rewiring, or gross malapposition for long stents, i.e. a floating stent. Malapposition is identified automatically by the OCT. Here you can see on the OCT angiogram in red, on the cross section in red, in the lumen profile on the malapposition bar, and on the rendered stent. It can have bad consequences to have malapposition. This is an example of a lost wire where the operator rewired. You can see that the wire went through the side branch, and what they ended up doing was inadvertently crushing the proximal stent because of abluminal and luminal wiring. Finally, for expansion, it's important to understand that expansion and apposition are different. Expansion is the ability of the stent to hold the lesion close to or greater than the normal reference segment, then the stent is expanded. Here in this example, you see that the stent is fully opposed based on the white bar, but the stent is much smaller than the reference segment areas, showing a 48% underexpansion. We should be aiming for at least 80%, if not 90% expansion if possible. There are 2 modes of OCT assessment of expansion. One is the tapered view. The other is the dual lumen view. We're moving towards the tapered reference because it automatically accounts for side branches. And here you can see the region of interest is automatically detected on tapered. The expansion is automatically displayed. In the event that you do end up underexpanded, well, of course, you want to use your post-PCI OCT to help determine the stent size. And just like we mentioned, similarly, in this situation, the distal half of the stent is underexpanded. In the distal reference, the artery has now grown by 1/4 millimeter. And so we can use a larger post-dilation balloon to perform our optimization. And then you can see we've rescued that underexpansion, which is now greater than 100%. In fact, you can even see the shape of the balloon optimizing the vessel wall. So we can perform MLD max guided PCI very quickly. This procedure was 25 minutes beginning to end with cabbage-like results, 100% expansion, absence of malapposition, and absence of an edge dissection. So thanks for listening to my talk on MLD max. And I invite you all to join us for our OPCI Live, which is an ongoing program for education for the interventional community, as well as the Heart of the Matter Journal Club. Thanks very much.
Thank you, Ziad.